Hi, guys. Thanks for joining. This is Essence of Medicine. Today, we're going to be talking about anesthesiology A through Z. I'm Amanda Armagast.
And I'm Dr. Abbasi, and I have here two magicians who are going to introduce themselves. By any standard, anesthesia is magic. But before I tell you why I think anesthesia is magic, why don't we introduce two of my favorite anesthesiology people? Brian, why don't you go ahead? You are a returning guest.
Thank you, Dr. Abbasi. My name is Brian Fleeman. I have a doctorate in nurse anesthesiology practice with over 20 years of anesthesia experience. I completed a non-surgical pain management fellowship in 2022 and have opened my own pain management practice. Been doing mostly pain since then, but I still do anesthesia on occasion, especially for special people.
Yeah. Beth?
Hi, my name is Beverly Trujillo, nurse anesthetist. I've been a nurse anesthetist for the past 10 years. I started off in Great Miami, University of Miami, worked for the Jackson Healthcare System, then came all the way over to El Paso, Texas, where I got the pleasure of meeting Dr. Abbasi. And I actually am still here in El Paso, Texas right now. I'm working for the Army Medical Center right now, which is a little bit different than what I'm typically used to, but it's very amazing, and being able to serve our troops and our vets in a totally different way.
I think one of the first question probably everybody has, we hear these names, anesthesiologist, nurse anesthetist, doctorate in the and nurse anesthesiology. Why don't you dissect this a little for us? What does it take to be a nurse anesthetist, and what qualification do you have on top of that to be a doctorate of this field? Bev, what did it take you to be where you are? What was your path to get there?
Well, I mean, obviously we started with the 4 years of the nursing education. After nursing, most CRNAs will go into ICU for about a year. I actually was a nurse. I've been a nurse since 2003, and I've gotten a chance to work a little bit everywhere in the jail systems.
You were a nurse since you were 3 years old?
Thank you so much. But yeah, I've been a nurse for a very long time. And I didn't really know where I wanted to go with my, originally, but I got a chance to see a little bit of everything. I worked for the Department of Children and Families, worked in the hospital, worked in an outpatient setting. But typically you really just need 1 year ICU. I went into CVICU finally. And after being there for about 3 years, started the anesthesia program at Barry University in Miami Shores. That program is about 3.5 years. Once you're finished, Barry now has like a doctorate program. So once you're finished with that, you go on, and some people specialize in other specialties, and other people just kind of start there on, and that's kind of it. I love the field of nurse anesthesia. You'll find us just about everywhere, in surgery centers, plastic centers, hospitals.
How long is the nurse anesthetist schooling? How long is that?
Typically right now it's like 3.5 years after you've done the 4 years of nursing, and then the ICU training, which is the requirement, I believe right now is 1 year for ICU.
Now, you go through the K-12, then you go to undergrad, then you go to 4 years of the nursing school, or how many years of nursing school?
Nursing school is 4 years.
4 years.
Yeah, get your BS.
And then you go work as a nurse for many, many years. Then you go 1 year to the ICU. By the way, whoever have to work in the ICU, they know if you can manage the ICU with all these lines in and out, you're a magician already. You're an astronaut. You go to ICU, there are 50 lines coming in and out, and any single mistake can kill the patient and so on. And then on top of that, then you go 4 years to nurse anesthesiology school, and then you become who you are. So, and that was not enough for Lord Fleeman, because
he wanted more.
As we have established in our previous podcast, you're old as dirt, right?
Yeah, that's right. Some days I feel more old as dirt than others, but
So tell me, what So why wasn't that enough for you, and what did you get on top of that?
Well, I will get to that. I just want to dovetail a little bit back just for our listeners. ICU nurses generally work 12-hour shifts, and their job is to vigilantly watch the patients, making sure nothing changes, and if it does, addressing those issues, which lends itself very well to anesthesia, because after we put someone to sleep and when we wake them up, that time in between, that's what we're doing, is we're eyes like a hawk on everything going on to make sure everything's perfect throughout the entire anesthetic. So I just want to kind of highlight that a little bit.
That's a very good point. Very good point.
As our background, and I did 4 years in ICU, gave us a lot of education and training prior to going back and specifying that and applying that to anesthesia practice itself. But I don't know why I went back to school. I love to learn, I guess.
Okay, for everybody, Brian has really put me to shame, because I listen to books in 2.5 speed, and when he listens to my book in my car, he starts smiling, and then he put his phone on. He listened to books 4 times the speed. so I can sympathize that all of that wasn't enough for you, because your mind is just need to be kept busy. So how much more education did you get after what Bev just described?
So yeah, after getting my doctorate in nursing anesthesiology, and that's what every CRNA now trained, a certified registered nurse anesthetist, so a nurse who does anesthesia, gets a doctorate in that anesthesia practice. I went back and did a year-long fellowship for non-surgical pain management. That's interventional pain management, which epidural injections, epidural steroid injections, ablation of nerves, and other things. And I guess what drove me to that is I always liked regional anesthesia, doing things for patients where we minimized how much narcotic we gave them, or even not having to put them to sleep at all, other than give them a little something that I like to call a little liquid courage, just something so they're not quite as anxious. But we can block a lot of nerves with local anesthetic, where patients can go through surgery and have no pain afterwards, and much reduced pain even after that, and a lot less narcotics, which has become an issue. Obviously, everyone knows about the opioid epidemic that's happening throughout the U.S.
Yeah. Now, what would you say the biggest differences are between the anesthesiologist and a nurse anesthetist? What are the major differences?
Background and training. I mean, they went to medical school, and then they did their fellowship in whatever they were trained. Again, like I kind of pointed out, nurses were the first to do anesthesia, for one thing. With our ICU training too, we get years and years of experience. I had over 10,000 hours logged of direct patient care prior to even going back for my anesthesia training. And that, again, is 90% of what we do is vigilantly watch the patient, making sure nothing changes. And if it does, we're there to treat it and take care of it.
From what I hear, there is no difference. If anything, your education is longer and more rigorous. This is what I heard, because you go to 4 years of nursing school, then you work as a nurse, you take care of the patient, then you go to the ICU, work many years there, then you go back again and to a nursing nurse anesthesia school and get your doctorate. So it is, if anything, your education is actually longer. Is that what I hear?
I would agree with that as well, especially specific anesthesia training, because those in medical school, they're going to learn dermatology, urology, all these other things that have some benefit, but they're not specific to anesthesia.
Yeah. Now, I know there is some differences from state to state, but can a nurse anesthetist like you, I know you're operating independently, but is it from your knowledge in most of the state that you can operate independently, or do you need any kind of supervision from anesthesiology or anything like that? What's your best knowledge of that?
Yeah, I know most states are different. Every state's different. I worked in Florida. CRNAs can't operate independently in Florida, but they can cooperate with anesthesiologists or other physicians if they're trying to open up a clinic. Within the VA system and the Army system, where I am now in El Paso, CRNAs are autonomous, and they operate.
As they should be.
Right. And then obviously states like New Mexico, from state to state, it differs.
Okay, I see. What about you and Kansas, Lord Fleeman?
Yeah, it's a very political thing, and I wish it would change. In Kansas, we've been physician supervision requirements were removed in 2000. So for 23 years, been practicing without that requirement. There's been no difference in patient outcomes as far as safety.
Mm-hmm.
It's something that I wish would change, and it's a very politically motivated.
Mm-hmm.
It has more to do with competition than with patient safety.
And I can tell you from my 30 years of experience that I would work with nurse anesthetists any time of the day, anytime. No, my best results and my best cooperation has been with people who have your background, because you do it every day. It is for you the actual work. You go to ICU, you see the nurse, and it is not theory. It's about actual work, and all that. You don't get any additional training on dermatology in your school. You get literally what's needed for your final job. So, but let's come back to that. Your job is to make sure that people like me can do what I do without patient jumping off the table.
Correct.
Is that an accurate description?
That's accurate. I mean, there are basically like three parts of anesthesia, right? The one that you just highlighted, you want to make sure that patients don't move during the procedure. You want to make sure that the patients are feeling really good and their fears and everything are calmed and relaxed. And then we also want to make sure they have no pain. It's basically those three things we work around constantly. Yeah. Like my colleague here is mentioning, he's big on pain and regional, and I'm pretty sure ERAS as well. We're now in the era of minimal is more. And so we want these patients to feel really good, want to do surgery again, want our surgeons to be happy. But doing it as effectively as possible.
So, Brian, how long have we had complete anesthesia? Because this knowledge is not that old, But if you read books even from 19th century, where four men in Civil War, where four men had to hold somebody down when they were doing amputation, that is why the surgeon had to be so fast. Because those four men who's holding the person down, they got tired.
Well, they still do that, just FYI. I'm originally from the Bahamas, and there are certain places where we still do the hold them down.
Wow. Wow. I want to know. You're talking about this century.
Yeah, this century. Actually, I fell off a tree as a child in the Bahamas, and that's what I got. I got to hold them down and begin. I don't know if you guys remember the earthquake in Haiti back in 2012. We did a lot of amputations, a lot of cases that when I was over there without anything, just kind of here's a Tylenol and we'll hold you for a minute and do this amputation. So,
wow.
Yeah. I just want to chime in here for those listening. Don't worry, we'll give you plenty of medication. You'll be happy. You won't remember anything. You'll be pain-free. You may wake up in a little bit of pain, but we'll give you medicine then too. So none of this applies to you guys. This is all perspectives from third world or wherever or ancient history. So no worries.
Okay. Now let me tell you something. I had twice general anesthesia, once as a 15-year-old boy. Let me tell you a story. This is a true story. When I was 11-year-old, a motorcycle drove over my ankle. It broke. They did not take me to the hospital. They took me to an old man, and all four of my uncle had to hold me down. And this old man, they pulled my leg to reset my fracture. I'm actually arguing it wasn't broken until he started pulling on it.
Didn't they tell you something too, like to put bread on it?
No, they actually put potatoes and eggs. They mashed potatoes and eggs. They wrapped around my broken leg because they said hospital is for serious stuff. You don't take a boy with a broken bone there, but four people were holding me on my four ankles. And then this old man was pulling on my broken leg to reset it. So that was almost 40 years ago. So I know pain.
Yeah.
But then later on, they had to do a surgery to undo what that old man did. And I remember I was on a table and somebody was looking at me, and then it was like a time machine. Now, my second general anesthesia was just a few years ago when I got a hernia repaired. And I have lots of trouble. I always wake up, my brain is working. That was one of my best sleep ever. So I was on the table, and all of a sudden, this deep, relaxing sleep. So for people who don't know, Michael Jackson died of an overdose of propofol. And that is one of the medication that you guys use. I want you to talk about that. But this anesthesia, both of them, they were like magic to me. That was the deepest, smoothest, most beautiful sleep I have ever had. It was like a time machine. I was looking at somebody, and then I was in another place, in another time, and so on. How do you guys do that? Tell us a little about that.
First of all, if Beverly or I did Michael Jackson's anesthesia and gave him the propofol, he'd have been alive. Don't let a cardiologist do your
Sure.
anesthesia. That's point number one. So,
Yeah,
So,
for sure.
now that you're talking about it, tell me about the details. What would you have done differently to keep Michael Jackson alive?
Well, there was no monitoring. You know, that was key. And like my colleague here mentioned, I mean, we're vigilant. We've been since day one, we're trained and we've been set up to always monitor, watch the patient. If you're breathing a certain way and for a slight second you're breathing differently, we're going to catch that. And so unfortunately for Michael Jackson, he was receiving very powerful sedative hypnotic with not accurate monitoring. You know, he stopped
driving with your eyes closed, right?
Yeah,
I mean, without the proper monitoring is like getting into your car, closing your eyes and starting driving.
Right. And you know, propofol and great. We use in sedation all the time for colonoscopies and quick outpatient procedures. I mean, patients normally are still breathing on their own as you're slowly giving it. So, I mean, he's at a decent dose, at the right dose, Michael Jackson should have still been breathing on his own. And if anything would have went different or he would have stopped breathing, you just needed someone to quickly act. I mean, it's a great drug. I hate that it got such a bad rap. Patients are so terrified of it now, but it's such a great drug, and it's quick on and quick off. And we use it a lot of anesthesia because it's great.
What is the name for that colloquial name of propofol? Milk of amnesia. Right?
Yeah,
it's white.
Milky, yeah. So how do you do your magic? Let's say I'm a patient, I've never met you, but I'm a surgery coming up. They tell me not to eat, not to drink after midnight and so on. But most of the time, 9 out of 10 times, I don't see you before, right? But you drive me through that. I'm told I need a general anesthesia and a surgery. What is next? What is your exposure? What am I supposed to do?
Well, I normally tell patients communication is key. The first step is that they will speak with a nurse from the operating room. Sometimes the nurses will call these patients a day before and tell them what meds to hold, what meds not to hold, what to drink. We used to do don't eat or drink anything after midnight, but different hospitals are adopting what we call like ERAS protocols, which just means enhanced recovery after surgery. So those NPO guidelines are a little different now, but that's patient specific. So patients, you know, adhere to the instructions. If there is any question, I always tell the patients, ask questions. If you feel like you didn't ask enough questions, please call back, because a lot of the times it's very imperative for you to follow those guidelines or you may have to cancel your surgery. So that's like step one.
Can you tell me a little, very short about those guidelines? What has changed? Like it was
most of the time, and I know my colleague here does more of the regionals and pain, so he's probably privy on this, but long time ago, it was like, don't eat anything after midnight, nothing, 8 hours or more. And, that was it. But now people are realizing that, for certain cases, certain patients, they'll have them drink like an electrolyte fluid, like something like Gatorade or Powerade or whatever, maybe like 3-4 hours before the procedure now. And we used to like suction out the stomach, and now we're realizing that, having stuff in the stomach during surgery is not necessarily a bad thing for a patient specific, and all these different things that we're changing a little bit more in anesthesia to enhance their recovery after surgery. So that's one thing. So MPO guidelines, follow it. And we're talking about MPO guidelines. Patients are taking drugs now that delay their gastric emptying, like Ozempic, that weight loss drug. So that's very important too, to disclose that type of information to whoever is doing the interview for you. Let's see, medications. They'll tell you, don't take this blood pressure med, take this blood pressure med. And that's very important. And if you don't know and you're kind of guessing it, call to clarify, because there are certain types of medications that kind of make it harder on our end to do our job. And it makes, patients' vital signs and their blood pressure a little bit more unstable during the course of the anesthesia. So they have to be very careful about that. Sometimes they'll ask patients to inject blood thinners, or sometimes they'll ask you to not take your blood thinners, so you have to really know and understand where you fit in, clarify, ask any questions, and make sure that you do it. And if you forget to do something on that list, let us know so we can either postpone, delay, or figure out what other actions we need to take.
And there is a process called clearance before the surgery. On my side, the clearance means that the patient is safe to go through the surgery, and that comes in two parts.
Right.
That the patient is safe to go through the surgical part, and the patient is safe to go through anesthesia part. On my side, like if somebody is on blood thinner, if you used to be very, very strict, platelets count less than 95,000. The patient is on aspirin, blood thinner, Plavix, and so on. Now, we are as well, surgeons are getting more nuanced that, like, I do my minimal invasive surgery on aspirin all the time, no problem. I don't open the lamina, so the epidural bleeding is much, much less likely, and so on. But there are certain things like, if somebody is on Coumadin, or if somebody is on Plavix, we cannot do my part of surgery. Now, are there specific medication or condition that is a no-no on your side? Brian, what do you think? Is there specific medication that you hate when you hear patient is on that before the surgery? Or not really?
For anesthesia or pain management?
For anesthesia.
For the anesthesia part, it depends on, if it's an elective procedure, any blood thinner, obviously, we're not very fond of. We're not going to cause the bleeding, but we're going to be responsible if there's enough bleeding that we have to administer blood. So, we won't be the one causing the bleeding, but we'll be the ones taking care of it.
Yeah. Amanda, the joke is in the OR, the surgeon stab in a major vessels and start the bleeding, and then says, "Anesthesia, what did you do? Lower the blood pressure." And so that's a big joke. That the surgeon always blame the anesthesia for almost everything.
Just about.
Last time Brian was making a joke. I was on the surgical side, and there was a curtain, and then obviously Brian was on the other side. Now, I want you to tell your joke again, Brian.
It's not a joke. So there's a drape that the surgeons and the scrub techs will put up that separates anesthesia from the surgical field. Well, this is otherwise known as the blood-brain barrier. And since all the blood happens on Dr. Abbasi's side, obviously on the other side, you got to figure it out.
That's why you guys have to fix everything. Everything that's going wrong is you guys fix it because you're on the brain side.
That's right.
Now, one of the problem on the anesthesia side as well is about a clearance on the anesthesia side. Sometimes you have to look at the patient before the surgery. Now, can you give me some condition, some medication, some medical condition, some situation that you really want to see the patient before the surgery? Because I would say probably half of the time you don't need to see the patient before, or it's okay to see the patient the day of the surgery for the first time. Is that correct? Is that assumption correct?
You want to take this or from an anesthetic point, there's a lot of reasons I don't necessarily need to see the patient. If someone's having active chest pain or they can't climb a flight of stairs without getting super short of breath, I would like to know those things. People that have sleep apnea that's not diagnosed or not compliant with their CPAP that come in, that I don't like either, because that can be a problem in the recovery area. And I'm focused airways first. So
yeah, they say ABC in medicine, right? Airway, breathing, circulation. Now, why don't we go around and just tell me the last 2 times that patient was there for the surgery, both of you, and you said this is not safe. I want to know more about those conditions, because patients show up, they expect having a surgery, but we are not going to do that if it's not safe. Bev, the last 2 times that you and the surgeon will love you for that. So tell me the last 2 times that you said, nope, hard stop, we are not doing this. Tell me what happened.
Well, one procedure we had was a patient came in on a wheelchair, and by the time we got to him, the patient was sitting in the bed, right? So the wheelchair is off to the side, so it's not really in the back of your mind. And this is going back to the importance of communication and telling us every little detail or change that has happened in your life. So it's a simple case. I think it was just for gallbladder removal. The nurse does her assessment, surgeon checks off the patient, and we go talk to the patient. And I'm talking to the patient and nothing strange comes up at all. As I'm rolling him back to the operating room, the patient goes, you know what? Over the last 2 days, my legs, because I was walking before and my legs just haven't been working. And I'm like, wait, what? He's like, yeah, I just started losing feeling in my legs over the last 2 days. I hit a quick U-turn and we went right back to the pre-op area. This patient was having, he was having issues with, he was having Guillain-Barré, but he just didn't understand what was happening. But he didn't realize that it was very important to tell the staff that I walked last week and this week I'm not walking. Like that was that little bit of information that we were able to,
well,
and that was like a last minute catch.
Too fast. Guillain-Barré.
Yeah.
Now you have to explain it and tell us. So you saved that person's life most likely, but explain what that is and why is it important?
Well, I mean, these patients, they start to have slow loss of feeling and movement, and even though it will come back to them with proper treatment over time, but they can even have respiratory issues. So it's like a slow climb. So you're losing sensation in your legs, it goes all the way up, and now you have issues with your fingers. I mean, obviously this patient didn't realize what was happening. He just thought to himself, I'm getting older, my legs aren't working, but that's not something very, it's not a small detail. And then over time, it just gets worse and worse. And without proper treatment, I mean, you can have some really major catastrophic issues.
Well, Guillain-Barré is an autoimmune disease that literally your neurons, they cannot control your muscles anymore because there is an antibody against your own receptor there. It used to be universally deadly. But with Western medicine, we can put you in an ICU sometimes for weeks and breathe you, and your body slowly will recover. But in a situation like that, you overstress the body with anesthesia, with the surgery, that can become a deadly situation.
Oh, yeah. Very catastrophic. And that was something that was literally caught as we're going into the operating room. And he's like, and Dr. Abbasi knows this, I'm a talker. So I'm always chit-chatting with my patients. And just in conversation, he just brings up this very, very important fact.
You see why it's important to be chatty?
Oh, yeah, for sure.
So the Brian, when was the last time? Now, Brian is a master of phrases, because I want to write just a t-shirt, phrases, multiple, like I said. Amanda, we should start making, like, one of his things he says I love is that I never canceled the surgery. What do you do?
Yeah, I'm not a surgeon. I can't cancel the surgery. I can cancel the anesthesia though, and the anesthesia. We'll
Just
go back to
cancel
our
the
early
anesthesia
conversations
part of
about
the surgery.
people being held down to have the surgery. Most people aren't going to be okay with that. So,
How about in the Haiti? They're okay with that.
so
So
generally, if you cancel the anesthesia, the surgery follows. But again,
yeah. So when was the last time you canceled the surgery and why?
um, it's been a long, long time actually. So I think
And
we're
it's
better
been a
at
long,
screening.
long time, considering we just did somebody with BMI 64.5 in your place, and you are a lion brand because yeah, I see the head shaking of Beverly, but BMI of 40,
I think
64.5.
that's normal in Texas. That's a
Well, I had the opportunity, I actually had a Zoom call with this patient well in advance. I don't remember if it's several weeks or maybe even a month ahead of time. So that face-to-face conversation is sometimes very beneficial because things on paper don't necessarily always translate to how someone actually is and doing. So it's real important to not only look at the lab work and the imaging and all the other things, but to actually look at the patient and talk to the patient and get a little bit more detail there because sometimes the paper says one thing, and Dr. Abbasi and I have done a little thing on that too with spine surgery specifically on how to correct the images, but not the patient. So
Yeah, yeah. Well, no, see, this patient really needed the surgery, but with BMI of 64.5, nobody wanted in North Carolina to take care of this patient. And Bev, we have done in El Paso together. Our surgery is so efficient, we can do it safely. Our society is telling us not to do surgery on BMI, elective surgery on BMI above 40, because this patient, heavy patient, laying on their chest, and I will come back to that, you know better. They are laying on their chest, and you are doing a positive pressure ventilation breathing rather than a natural breathing, which is a negative pressure ventilation. And I will come back to that. Now, imagine you do it on somebody heavy for 8 hours, 10 hours, 12 hours. The other patient with a BMI just 50, and they went to the university. They were the anesthesiologist there was saying, no, this is not a 1.5 hour surgery. This is a 12 hour surgery, because that is how long it takes for them to do that. We did the surgery with some nurse anesthetist somewhere else. It took us 75 minutes. A surgery that's 75 minutes is doable. A surgery that's 7 hours, 8 hours, 10 hours is not doable on the same patient. Now, this patient came to us in Hutchinson, and the next day she was singing Amazing Grace before she was discharged with a BMI of 64.5. Now, but talking about that, so I think that's a testament to your ability that you haven't canceled any patient. But is it true that you have never canceled the anesthesia part of any surgery ever?
it's been a long time.
Good.
I mean, again, it's communication with the surgeon, and hopefully things are gonna. And I understand what happened with Beverly's situation, because sometimes we don't get a chance to talk to patients until the day of. But I think we've gotten a lot better at screening, and if there's any issues, there's communication done well ahead of time to kind of resolve these issues before they come up. Because even in the patients that have come in with really high blood sugars, or I guess that was probably the last one, was that with very high blood pressure. We ended up not doing the surgery, but again, I didn't cancel it. I just went and talked to the surgeon and said, hey, their blood pressure is completely out of control. We sent them off to get their blood pressure more under control and then come back. So we delayed the surgery. I don't know if we canceled it.
What
Didn't do it that day.
Cold symptoms? I had a procedure scheduled for today actually, and my doctor asked me to cancel my procedure because I was having cold symptoms. Why is that?
Well, sometimes it's a respiratory issue, right? You're gonna have a lot of mucus down there, especially if I have to do an intervention or we have to put a tube down there, now it's clogged with mucus, and it just causes an issue with ventilation at the end of the day. And if it's a necessary procedure, like let's say your body depends on this surgery or you're not going to make it, yeah, we'll still do it, but if it's something very minor and simple, no one really wants to, the risk benefit, because like every surgery, every procedure has a risk benefit, right? you don't want to put the patient at a greater risk than what the benefit actually is, for anything.
Now,
And we
let me
don't want
tell you
your
something
cooties.
yeah, mucus. Actually, I had a patient who's COPD, bad situation to start with, but my surgery is like 45 minutes, very doable. After 20 minutes, patient's SAT start dropping, and literally they couldn't ventilate the patient. We turned the patient, and there was the thickest mucus in the tube.
Yeah.
Like, unbelievable. I have never seen something like that.
Those mucus plugs, they'll get you every time.
Yeah, and I think that was, and this is very dramatic that you are in the middle of the surgery, that you have to stop, you have to turn the patient, you have to, because in my surgery, patients are on their belly, we call that prone. So, and as well, that certainly this situation, like that somebody like that could never get open surgery. But in that situation, it was considered safe, but 20 minutes into the surgery, now that mucus plug really changed the situation. Now there were some other situation, but what is the part of the thing you do? You give patient medication even before you start the surgery. Run me through it. I am now cleared for the surgery. Everybody's ready. I have my lines. You can access my blood vessels and give me medication. What is the next step? You make me comfortable. I always go and say, I have talked to the patient. I have signed. We have talked. Consent is good. Go pre-medicate the patient. What does that mean?
Yeah, so I mean, like going back to the 3 aspects of anesthesia, first we want to calm your fears, right? We want to make sure you're comfortable and relaxed. So we do normally, most of the time, we'll give a patient like a sedative hypnotic medication called Versed. It'll cause them a little amnesia, make them feel really good, make them feel a little relaxed. It also helps the anesthetic overall work better once we get back into the operating room. And so that's first stage. We different hospitals are different. Most of the times we'll give that Versed in the preoperative area, in that Bay Area. Sometimes they want the patient to have that medication in the OR. So it just depends where you're at. And we start off that way. Once you're in the operating room, it's a little chilly in there for good reasons, and then we have the oxygen mask that we'll put over. And we always relate it to like a NASCAR, right? Like, I mean, then you'll see like a million people touching you all at once. The nurses are there, CRNA's there, whoever else, people are marking, they're applying leads, monitors. And I always try to calm the patient's anxiety and say, hey, I know a lot of people are touching you right now. It's okay. We're just setting you up and getting you ready and making sure that, we're monitoring you and are able to monitor you efficiently. So, I mean, that's the next phase. After that, we have them breathe the mask, and every provider is different. Some people like to do the count back to 10. Some people will ask them to go on a vacation somewhere in their mind, or, whatever scenario your anesthesia provider tells you, just go with it. You're breathing oxygen. And I think that's the last thing a lot of patients remember is taking in that nice deep breath, and we start giving you medications from there.
But that pre-medication, that patients are anxious, and I go and tell my nurse anesthetist, pre-medicate the patient, make him comfortable.
Right.
What is it?
It's Versed normally.
What is it?
Versed.
Versed? What does Versed do?
By class, it's a sedative hypnotic, and it's just going to make you, it shouldn't knock you out. You're still going to be awake, but you're just going to be in a calmer state. And you're going to probably laugh a little bit more than normal. Your heart rate will come down a little bit better. You'll be in a better jolly state for us.
Okay. So, and is that given that when I'm in a waiting room or in the pre-op, I'm staying there, they come and give me something in my IV, that is Versed, I'm assuming.
Yeah. Right.
And then is there anything else they give before they roll you to the OR?
Some people are different. Everybody has their own cocktail. Some providers will start giving medications to prevent nausea and vomiting out there. There's a little scopolamine patch. We call it a scope patch. There's another name, a layman's term for it, I forgot. But it's going to be like a tan circular thing that will go behind your ear, and you can keep it there for 3 days. It helps with that motion sickness type nausea and vomiting. And then some people have gotten really fancy over the years, and they might give patients other medications like Precedex, and other different types of medications that will help calm you a little bit better. Yeah. I mean, people have their own cocktail, but most of the time, if you can tolerate it, Versed is normally always thrown in there. For short procedures, though, like let's say I'm doing like a colonoscopy or something super quick, I normally don't give Versed. It just delays them a little bit longer for the docs and stuff. And if you're older, every provider has their own cutoff with sedatives. We tend not to want to give it to patients that are like 70 and older because it just impairs their cognitive abilities for a longer period of time than the average person. So
now, Brian, any other magical medication you give the patient before patient goes to the OR?
Well, we're talking about liquid courage. That's the Versed or the Precedex. So that's liquid courage that I always tell patients. I'm going to give you a little liquid courage. You're going to be really brave after this. I also believe in verbal Versed, which is just reinforcing to the patient that verbal Versed. So I just talk to them and calm them down with my beautiful voice.
It's okay anesthesia. It's gonna be okay.
Yeah, communication is one of my favorite stories, which actually got brought up today. I did anesthesia this morning for open heart surgery, but we always tell the patient to center themselves on the bed if they can, because the beds are pretty skinny because the surgeons don't want to lean way over and have back problems themselves. So the beds are super skinny. Well, I put a yoga instructor to sleep once, and I said, center yourself. And she's thinking, center myself. She's like,
that's what I was thinking too. I was like, that's a good one. Center yourself.
Because I woke up and I was just so relaxed when you told me to center myself. And I'm like, that's what I meant. Yes, exactly.
So I'm now in the OR. I'm scared, lights, people are just walking around and so on. What's next? I get a mask with oxygen, I'm assuming.
Correct.
Comes with something, that metal piece that it looked like they want to shove that in my throat.
Well, most people aren't awake at that point. Like if you see the metal piece, we're doing something different.
I think he's talking about the tube tree.
Run me through it.
But anyway, go ahead.
Oh, you're talking about the tree? Oh, the Christmas tree? The Christmas tree. Yeah, the metal piece that holds the oxygen mask on there. So yeah, we put the oxygen mask and we have you count back to 10 and then that's it. That's what most people remember. For us, that's when everything starts for us. So it's the process of induction when we start to induce the anesthesia, and we give meds like going back to propofol, that other sedative hypnotic we were talking about that now is related to Michael Jackson, unfortunately. We give other medications to help with gag reflex. If this is going to be general anesthesia, we're talking just about general because I know there's different types. So this is general anesthesia. So if it's general, meaning that you're going to be completely asleep, all loss of consciousness, and we're going to make sure that you are ready for this procedure, we're going to then give you a medication that's going to prevent movement because we don't want your body moving during the surgery with the surgeon. So we give you those 3 to 4 meds. And once your body is completely asleep, completely ready, and remember, we have monitors that are, hooked up to you, and we can see when you're ready for us to start to then put a tube that will go into your throat. Once you're ready, all our numbers look great. We go ahead, we put that tube in. Then that tube is hooked up to our anesthesia machine through a little circuit, and gases go in and out of that circuit. And those gases will also help keep you asleep for the whole procedure and help with mobilization as well. And during the whole case, now we're just monitoring. We're monitoring your heart rate, your blood pressure, your respirations, your oxygenation, everything, your muscle twitches. We're monitoring everything. Every surgery counts for different things, and our surgeons will want us to monitor different things. If we have to monitor labs or monitor, every little thing about you, we constantly communicate with our surgeons as to, okay, what's next? What else do we need?
Let me just try to understand this now. You induce the anesthesia with, you ask me to count backward, 10 down to 1, and you're giving me propofol. And somewhere around 5, I'm gone.
You're gone.
And you give me something that I cannot move and remove my gag reflex while you are getting prepared to put a tube in my throat.
Right.
And that tube is controlled, is connected to a big machine, fancy machine. What is it called? Anesthesia machine or respirator? What do you call that machine?
basically, we all call it the anesthesia machine. Yeah.
And that
It's
comes
like a mixture of a ventilator and a gas machine. And, we're able to, like, most patients are used to seeing a ventilator in the ICU. So if you can imagine a machine like that, but now it's also attached to different units that allow gas to go through. And it's a little bit, it's a little better than the ICU ventilator. We have better modes and we can fine tune it a little bit differently. But yeah, we have that machine that will help us greatly during the course of, it's the main player in the game, really.
Yes. And now this is a huge difference, right, Brian? This machine pushed the air to your lung. Rather than when I'm breathing, I increase the volume of my lung or chest to suck the air in, meaning that a natural breathing is a so-called a negative pressure ventilation.
Right.
And what you do is a so-called positive pressure ventilation. We have to push the air in. Why is that important, this distinction? Why is it important?
Well, both to ventilate the patient, to oxygenate, get oxygen in, carbon dioxide out, and then also there are anesthetic gases, as Beverly alluded to. So Beverly and I are both gas passers for a living. I say that to some of the people. I pass gas for a living. It's true. So, and also with positive pressure ventilation, what we're doing, you have to be careful in some patient populations because of how their lungs are designed. And we don't always have to put somebody on. A lot of times I can get somebody to sleep, put the breathing tube in, and they're still breathing on their own. They just don't know I ever put the breathing tube in, and they kind of keep themselves asleep. So there's a lot of different ways to do it. And sometimes we use IV agents only throughout the case and not gas. So there's several different ways.
Yeah, but what I'm getting at is that because this is not the natural way of our lung operating, when you put somebody on positive pressure, that especially if there's a long period of it, like, you do a 12-hour surgery, especially when the patient is big, laying on that, you create a lot of pressure. And there is good studies that they show there is a barotrauma to the lung. And this is a long time, high ventilation pressure and so on. That's why you control it so well, right? That is what I think it makes a huge difference if that anesthesia is 10 hours versus 1 hour, because then you have a barotrauma for 10 hours versus 1 hour. Another thing is that, as well, you just talked about those gases. And God bless their heart, the first gas that we had was chloroform that we don't use anymore, because we know it caused lots of problem. It become toxic in many ways. And then they had ether, and then they have these fancy gases. By the way, to my best knowledge, we don't know exactly how they work.
Right.
Or do we know exactly how those gases?
I mean, but honestly, like most meds in the US, right? We don't know exactly how they work. Like, I mean, certain meds, we thought they worked this way, and now we're finding out, oh, you know what? That med actually also does this. So it's always like we're always constantly learning. And we don't even know fully how the brain even operates, So a lot of the things are just constant learning.
What do we use these days? Isoflurane, sevoflurane, what do we use? These are fluorinated complex carbohydrate that literally what we understand, they go to the membrane of your nerves and they just reduce their ability to shoot the action potential, and then they make a general sedation. But then the advantage is that you breathe them out, and then the membrane of the nerves, they stabilize themselves, and then you come out of anesthesia. And that happens pretty fast, meaning that the amount of the gas you give, you can control the depth of the anesthesia. But you are the expert. Please tell me, how does that work?
Well, yeah, just like you said, it happens fast for the average small 70-kilo patient with no respiratory problems, whatever. And different gases act differently. I think most operating rooms across the nation probably rely on SIVO. I've worked in many hospitals. I'm trying to break it down as layman's as possible. Well, most hospitals don't have all the gases, basically, and they just have learned to probably just use one of them. And some places have the luxury of 4 or 5. I work for the government, and the government has almost everything you ever can dream of at your disposal. So we have I have the opportunity of using meds that I haven't used as a civilian in a very, very long time. So it really just depends on the institution that you're working with also, right? That you go to that has the different supplies. Certain surgery centers, they're more about budget, so they won't have all the different types of gases. But yeah, for the most part, our gases, they come in, and just like you said, they're going to help with immobilization for the patients. They're going to help with the surgery, and they're going to help decrease those action potentials. So Dr. Abbasi, he does a lot of neurosurgeries, right? And a lot of our neuro docs don't want us having our patients on a lot of gas. So they'll ask us to do something, combination of what Brian alluded to, is giving more of the IV medications and less of the gas itself. So certain patients will have procedures where we're not giving them a lot of gas or zero gas at all. And then we're just relying heavily on our IV medications, which consists again of propofol and some Precedex and some other IV anesthetics that we will normally use.
I definitely have to not ask you. I know some of those gases are extremely expensive.
Oh yeah, that's hence why some places only have one. Des is one of the most expensive gases, and I think it has the way it's stored to desflurane. It can be a little irritating to the lungs and airways, but this gas is very quick and very quick on and very quick off. It works very well, especially for our obese patients. Gases sit a little bit longer in bigger patients. So when you're doing cases with big patients, you might prefer to use a gas that can leave the body quickly, especially when it's time for you to wake them up and you don't want to just sit in the OR for a very long time. But if you're titrating it right, you can kind of use all the gases the same, right? So whether it's iso, sevo, or desflurane, which is the name of the three gases that we use. In Haiti, I actually use halothane, which is back in one of those gases that we don't talk. The US, I don't think even uses halothane anymore, but it's
nitrous oxide, the laugh gas.
Oh yeah, oh I love that one. Yeah, we use that one a lot too. We use that a lot.
Is it still used?
Oh yeah, yeah.
That's
yeah.
right. So
Yeah,
that's why everybody's happy in the OR.
Yeah. A quick point just about the anesthetic gases. We talked about people that have a little higher BMI, but also the length of surgery. The longer the surgery is, the more of that gas is actually absorbed into the adipose tissue or the fat tissue. So even though you breathe the gas off, some of that's stored in the adipose tissue. And then, if you have an 8-hour anesthetic, that gas is going to be constantly going into the bloodstream from the fat, and then the patient's going to breathe that out very slowly over time. So, the longer surgery and the longer anesthetic, the longer it takes to recover from all of that.
Note that you mentioned that, I just have to ask that because some, excuse my French, old farts in surgery, they say anesthesia time, surgical time doesn't matter. Do a good job. Doesn't matter if you do it in 2 hours or 8 hours. It doesn't matter. Two anesthesiologists here. Time under anesthesia, does it matter?
It matters a lot. It matters a lot. And I tell patients this, I tell the surgeons this, especially if we're doing cases and I worked in teaching facilities all the time and I'm all about it. But if the teaching is taking a significant amount of time, now we're just like risking the patient health more than anything. And going back to that COPD patient you're talking about earlier, having borderline sick patients under anesthesia for 1 or 2 hours, okay, we can make that work. But at 8 to 9 hours with those gases, like the sevoflurane gas that most hospitals always have, it has a lot of effects on the heart as well. It just is not something that you would just want a patient sitting there for a prolonged time. And going back to that positive pressure ventilation, we're talking about barotrauma, you're talking about problems with the alveoli, you're talking about collapse. It's not good for any patient to be under anesthetic that long time. It also changes our type of anesthesia, right? So like Brian probably does more regionals. If you're gonna do a hip surgery and you're an older person and your heart's not the best, we might want to do a spinal on you, which is going to be better for you overall. But if your surgeon's going to take 8 hours to do this procedure, then I can't do the spinal. I'm going to probably either have to do general anesthesia or we won't be able to do the procedure at all. So time affects the type of anesthetic we use, time affects, your overall outcome. Patients will have blood clots if it's too long, because, the natural blood flow isn't even the same under anesthesia for a very long time. So you're going to have a lot of stasis with the blood and a lot of other issues. So time is, I think, of essence in the OR. Time is of essence.
What did we do last time I was in Kansas? Can you describe what we did?
Last time you were in Kansas?
Yeah, what did we do?
We did 8 spinal fusions on Monday. I got an email that said 7, but I'm pretty sure we did 8.
Yeah, we did 8 actually.
I was in the room for
Yeah.
all of those, so I remember 8. So we did 8 on Monday, and then I believe 5 on Tuesday. Some of these were single level fusions, some of them were 3-level fusions, a couple 2-level fusions. But it took us 12 hours to do all 8 on Monday.
Yeah, well,
wow.
we did 8 Monday and we did 6 actually Tuesday. And the magic part of that is that all those 8 patients went home next day.
Yep.
Every single of them. They recovered just faster. And Bev, you remember when we were there, you were describing how those patients that after short anesthesia time wake up versus the regular spine.
Oh,
You
yeah.
know, you did such a fantastic job explaining that. So enthusiastic. You were so like, what is the difference with what you used to observe then? A regular spine patient versus that 1-hour surgery, how they wake up. By the way, I'm just quickly going to share a screen here for a second. You know exactly what a difference it makes. Every additional half an hour under anesthesia adds 17% to the combined risk of the surgery. This is a meta-analysis of 400,000 patients. And if you put them all together, we calculate that the additional risk involved, every additional half an hour, 30 minutes under anesthesia alone adds 17% to the combined risk of the surgery. And this is for everybody. People who are prone, that is actually higher.
Oh, yeah.
Actually, surgeries that are less than 2 hours are half as risky than surgeries that over 2 hours. But more importantly, as well, this is not just limited to the surgery itself. We know with all the neuropsychological studies, these long anesthesias that we thought they are harmless, they are not as harmless as we thought they are. Right. So if you can, it's not about being able to do 8 surgeries in one day. That means you do that surgery. We did some of those surgeries in 40 minutes or half an hour, where otherwise it would have been 4 hours. This combined reduction in the risk carries over to overall outcome of the patient. So, Bev, how waking up the patient after the surgery, after the shorter versus longer anesthesia, I need your both input on that. What is the difference between having a shorter anesthesia versus longer anesthesia in overall anesthesia and recovery from anesthesia?
Oh, the first time I did your case, and Dr. Abbasi knows this, when I was at UMC prior, our those neuro cases would take 5-6 hours, right? So you're thinking 5-6 hours, even longer sometimes, depending on who's doing the procedure, on your back, not on your back, I'm sorry, on your belly, prone, face down. We're ventilating you sometimes if these patients are obese, because El Paso, Texas has a very obese population. It's been very difficult to ventilate you most of this case. Now the surgeon is done, and now we have to flip this patient over to wake them up. If you're under anesthesia for that long amount of time, first I have to do pulmonary toileting, which basically means I gotta recruit your alveoli. I gotta suction your tube. I gotta do all these different extra things with my machine and with my hands to make sure that your lungs are gonna be okay, right? Then you're just swollen and puffy. So we have to sit you up to get some of that draining. Around your trachea is swollen. So we got to make sure, we are able to sit you up before we can even take the tube out. So the process of waking that patient up in the OR could be 30, 40 minutes after such a long case, versus when I first worked with you at UMC in El Paso, I was able to turn that patient and wake that patient up within 10 minutes. And we were out the door. And that patient was awake and in recovery and following commands. Even the nurses were shocked because they'd never seen anything like that, especially with those type of spine cases. And when we heard she was being discharged, the whole the whole recovery room was like in shock. They were like, "There's no way she's going home today." I'm like, "No, no, no, she's going home today." So it's just it's a difference. It's like a complete 180. It's amazing.
So, Lord Fleeman, what do you think on those long? You have done a lot of open spine surgery versus this, the short versus long anesthesia. What's your take on that?
Well, similar to Beverly's, I mean, if you have a 6 to 8 hour anesthetic for a long open back surgery, again, you like she said, flip them over and then you're waiting forever to get them awake, even though a lot of times they may even be breathing okay, but they're just not going to wake up. And they have all that gas, even when you get them awake and they're talking to you over in recovery room, those gases are still going to go back into your bloodstream. You're still going to be breathing them out. You're going to have bad SIBO breath for 24 hours. So just the longer the anesthetic, it just takes longer to wake up.
So what is your experience with the cases that we have done so far in Hutchinson? We have done a lot of cases, and you do still open surgical cases. One of the word you use is that for open cases, you are just fighting to keep them alive with 50 lines going in and out. Whereas in my patient, you're just making jokes, telling that the brain is on your side and blood is on my side. So, one of the jokes what I love when the anesthesiologist is sitting there on their cell phone and whatever they are doing. When they stand up and start looking at the monitors, and even worse, when they call another anesthesiologist in, I get really, really concerned. So I love it when you guys are there and on your cell phone, and I have to wake you up.
Beverly and I are never on our cell phones. We're watching the
Ever.
monitors and the patient, just to set that right now.
All the time. All the time.
No, but you have done a lot of these cases, and you use that really with your words. What you describe in your words, open surgery versus MIS, long surgery, short surgery, recovery. What is your experience, Brian?
Night and day experience difference. It's just, I don't know how many people that are listening now have had their appendix or their gallbladder out. If you've had it done recently, you've had it done laparoscopically, as opposed to where, that take your gallbladder out before they did this big incision down here, open you up, higher infection risk, more pain, just a bigger surgery. And now they do that laparoscopically. It's shorter time period, less pain, less everything. This is similar to that, where you're not having this giant open incision in your back and having a lot of blood loss that we're having to put fluid or even blood or medications to keep your blood pressure up because we're losing so much blood. Now we're, these fusions are being done through basically laparoscopic devices, cutting down on the pain, the time for surgery, and everything else. I love it because I'm getting old and my bladder fills up quicker, and then I got to go. Sitting in a 6-8 hour case would be very painful for me these days.
Now, this patient as well, you mentioned that there's less blood loss because the surgeon, that's what the surgeon does. We cook the tissue to stop the bleeding, and then we cut more and more. So the difference in that time frame is not about your anesthesia and your gases, but as well, we cause a lot of damage in that time frame. And I see as well on the surgical side that the recovery, patient go back to work and life within days rather than weeks. Now, go ahead.
Oh, and I'll also point to bring out, it's like fluid deficits and fluid shifts. When you have long procedures, those numbers get worse and worse. So, patients who've been under surgery for only 1 or 2 hours, because the body still needs, fluid, it still needs, and even though the blood loss, you may not see it on the floor, on the drapes, there's a lot of stuff that's happening inside as well. There's a lot of third spacing of fluids inside the body, and those numbers get worse and are worse for the patients the longer we're sitting in surgery,
Last thing, okay, patient is out of OR. Now you have to wake the patient up. The fun part begins, and some patients wake up. This is really exciting. So I like to go a little over the time. It's a little, so waking the patient up. Some patients wake up easy, some patients wake up rough, and so on. Tell me, guide me through it. I woke up and I'm told, first time I woke up, I was beating everybody around me. The second time I woke up more civilized. The first time I was 14 years old or 15 years old. The second time I was 40 something years old. So tell me, why are some people wake up more rough than the others?
Statistically, younger patients will wake up a little bit more wild and delirious, than older patients. Patients who've taken meds or on steroids or are athletes typically will wake up a little bit more violent. But going back to when we first talked about communication and talking to your anesthesia team, these are also details that you let them know, like, hey, the last time I had anesthesia, they told me I punched someone and I woke up violent. And so those little things really help us. And we do give medications as you're waking up as well to help smooth the process a little bit. So if you told me that you woke up violent your last time, I'm going to give you Precedex as we're waking up. I'll give you some other adjuncts, and I'll stay away from meds that will cause you to be a little bit more delirious than others, and work that way. Sometimes patients do better with less gas and more the IV stuff, and sometimes we can just avoid both altogether and probably do more so what Brian does, do some regional, block that nerve, and just give you a little bit of medications to calm you down during the case.
Have you guys been punched?
I have not been punched, but I have witnessed a punch.
In the OR?
Yeah. I
No, after the surgery in the PACU or wherever.
No.
Okay.
Only
No,
excitement.
what you don't know, the Brian is the kickboxer, and he tells me when he get punched in the face, he start laughing. And I watched him in one of his kickboxing. That was brutal. And he get punched, and he's just coming so happy around that. That was, so you haven't ever gotten that. You were never so lucky to be punched by a patient after the surgery yet?
Not yet.
So no, there's phases of anesthesia after the surgery. That at certain point, obviously you're with the patient until patient wakes up, and then at certain point you pass that patient in the PACU to a nurse.
Right.
What are the criteria that you say it's safe for me not to be there all the time? So what is that criteria?
All right. Well, all their vital signs have to be great. So that patient's heart rate, blood pressure, they have to be breathing well and on their own. Sometimes you might have like a little device in their mouth just to keep that tongue from obstructing their airway. That's fine. But for the most part, this patient shouldn't require any additional help to be able to take in nice deep breaths. Certain hospitals have different criteria. Some hospitals want that patient to be following commands, being able to, squeeze their hands and, so forth. In other facilities, as long as that patient can, have stable vital signs, and if they're still sleepy and sedated, that's fine, as long as everything else checks out.
Yeah. And Brian, anything additional that you think, that from transition that patient now from a PACU post operative care unit to regular floor, what are the criteria in Hutchinson that we say, it's safe now to move the patient from PACU to the floor? Even step down, less immediate care.
Sure. Obviously, the patient's awake enough to respond, and their nausea, vomiting is controlled, which we've gotten a lot better in anesthesia. Really shouldn't have much issue with that at all anymore. Occasionally you can get some, but we're really good at preventing them now. Their pain's under control. I mean, those are the three big things. They're able to, communicate with you. They're awake enough to respond and have a conversation with you. Nausea, vomiting, and pain are under control. It's time to get to the recovering part.
Yeah. Now, that's I think for the next or last 5 minutes, I want to discuss with you a case that is very close to my heart, and this is a patient that has given me the best feedback, the happiest patient. That this is a patient with a BMI of 52. Literally, the patient has made lots of painting for me, has brought the fruit basket. Amanda knows who I'm talking about. And you guys know what I do. What I do, if 5 other surgeons tell you cannot have a surgery because surgery will kill you, I do that surgery in 45 minutes and send you home next day. And then you go back to your life within a few days or weeks. But this specific patient, 50 BMI of 52, meaning large, but not super large. and it has a, by any standards, it's something that she's losing function. She's in a bad shape. And the patient had about 6 years ago, or 6 years ago, has one episode of provoked DVT. This patient has a practically DVT and blood
What is
clot,
DVT?
the deep venous thrombosis, and then pulmonary embolism. She was on the contraceptives 6 years ago. Has a provoked DVT, and since then is on some anticoagulant, and she goes to a first the person that covering for her usual PCP, primary care physician, and that person doesn't have time, doesn't want to really spend time, says you're not cleared for the surgery. And then the patient goes next day to another a primary care physician who takes the time, look at everything, and then says flying colors, low profile, low risk, go ahead with the surgery, no problem. So you have within few days two contradicting clearance. The first one says not cleared, the second one says cleared. All the information that's available to you, and all of that makes it to your desk. What is your next step? Beth, you get those two, and again, you don't know the patient, you haven't talked to the patient, you just have these two conflicting letters. The first one says not clear, the second one, a day or two later, looks at that low risk, go ahead, and so on. What's your next step, Beth?
Well, investigations a lot of times, and I always tell a lot of times we ask so many questions and we just can't get answers, and sometimes your patients are actually can give you some of the best answers. So I also try to include them if possible and if it's available.
So you would, for one of your next step is talking to the patient,
right? Including the patient, because sometimes information, like someone might get information differently or interpret it, or even though you have two probably very qualified health professionals and they give you two separate opinions, someone probably did not see or hear one slight bit of information that would have changed their entire mind, or how they would have proceeded.
So it would be, are you telling me it would be when you have these two conflicting things, your next step is not canceling the case, it is talking to the patient?
Oh yeah, for sure.
Brian, what do you think?
I 100% agree.
Okay, now how unusual is, instead of that, just with that what you just described, two conflicting things, without talking to the patient, without talking to the surgeon, just canceling the case? So would that be, what would you say about that?
I mean, I would just say sometimes providers, they get so busy and overwhelmed that if they're just canceling it, it's just for lack of investigation, right? It's like maybe it's late in the day and they just don't want to be bothered with like trying to figure out what's happening, and they'll just cancel. But with better time, and we've seen it. It happens in cardiology, neurology. We get clearances all the time that conflict with each other, or like one doc will say, high risk, the other one will say, no, they're fine, low risk. So you want to see what each provider, why they interpreted the data like they did, right? And then you want to ask the patient and talk to them, well, what was happening that day? What was going on? Maybe they were on a med that they stopped taking, that maybe that provider didn't feel comfortable with them being on that med.
Let's come back to this specific case, because that's very close to my heart. This patient, first of all, is losing function.
Right.
This patient has all the available data is for you there. It's in patient's chart. Provoked DVT and pulmonary embolism 6 years ago, never has repeated. Patient had a gastric bypass surgery, and later on we found out that anticoagulant is not even being absorbed. 4 days later, actually the hematologist says, no problem, no issues. You don't even need the anticoagulation. You don't even need to bridging, but you're not there yet. This is 4 days after the surgery that was canceled. Now, you are there, you have two conflicting things. The first step is for you to talk to the patient, talk to the surgeon. Right. Okay? So now, imagine now that how would you react if a surgeon sent a patient, that patient that you canceled, to a higher level of care, like you're in a small hospital,
Right.
that surgeon says, no, this patient needs surgery, send the patient to a university or some higher
Right.
level of care.
Right.
After you cancel the surgery, how would you react?
After I've canceled it, yeah, I mean, you kind of feel, I would feel bad, right? If I were the one that
What would
canceled.
you feel bad about? What would you feel bad about?
Well, because now that you're looking at someone else is like, no, this patient's fine, and especially if the case goes fine, that that I wasn't thorough in my investigation enough to see if this patient could have met criteria for surgery.
So you would
And
feel
going back,
bad about but that you didn't provide care. No,
right?
you wouldn't feel bad about that the surgeon sent the patient for a second opinion. Or
No, I wouldn't feel bad that the surgeon sent for a second opinion. Not at all. Not at all.
yeah,
Going back to risk benefit. Go ahead.
Go ahead. No, go ahead, please.
No, just risk benefit. When we're talking about risk benefit, like if you have a patient that's losing sensation and they need the procedure itself, and I think due diligence would make you want to investigate more to get this procedure done for this patient, especially if this is an event that happened 6 years ago. I mean, people have MI 6 years ago or whatever. The body changes and things change. So if so I would go more or lean towards that the patient needed the procedure more than just cancel it. Yeah.
So Brian, what is your take on this scenario? This is a specific scenario. And the patient, now, by the way, this patient later on went on to fall because losing function, had to go to the ER. And later on, I did that surgery somewhere else. It took me 1 hour and 17 minutes. We lost 50 cc of blood. That's the patient really loves me because of that. But you are few days, actually a day or so before the surgery, you have these two conflicting letters. The one that says patient is cleared is is newer than the one that says patient is not able to have the surgery. I think you and I, we talked about this case a little. So what, in a situation like that, what is your take on that? What is your next step, Brian?
I called the patient. We had one recently in Hutchinson that someone said not cleared for anesthesia because they couldn't climb a flight of stairs. Now, generally, when you can't climb a flight of stairs, it's because your heart or your lungs are bad. Well, I call the patient, I can't climb a flight of stairs because I hurt really bad. Oh, well, that's different. Then you're probably going to be okay. So talking to the patients.
I hear that you guys as well call me. You need to know what kind of surgery it is, right? Right?
Call the surgeon and the patient.
But you know what surgery it is. Now, it's interesting. Now, this patient, I send the patient to the university for the second opinion. And then the anesthesiologist, they tell to the patient, after patient telling anesthesiologist, this is going to be 1.5 hour surgery. Anesthesiologist, no way. This is an 8 to 12 hour surgery.
And that goes to knowing your surgeon, right? Like if you don't know your surgeon, right? And if I have a patient I'm afraid might have a blood clot under surgery, and if the surgery is going to be a long surgery, like 8 to 9 hours with a high risk of clots, and I can see where I would lean towards that. But if I know my surgeon is going to get me in and out of here, the patient needs the procedure, and the newer clearance was fine, then you're all go for it, But unfortunately, a lot of these things are very subjective too. It's like provider preference. Some providers are not comfortable, right? Or they don't have the resources. The hospital doesn't have the resources. So maybe they're thinking, we don't even have ICU beds. So if something happens with me, so there's sometimes a lot of other reasons why, I don't know if this is the case, but there are other reasons why people think not to do the procedure, depending on what the facility's capabilities are afterwards.
So would that be in any way, you would be having any objection for surgeons send the patient to a higher level of care to get a second opinion from another anesthesiologist?
No, not at all.
No. Brian, what do you think?
Nope.
Is it anything? No, the second opinion is practically a hallmark or one of the foundation of medicine, right?
Oh yeah.
So would you get offended, Brian, if I send the patient to the hospital side and say, let another person evaluate the patient? Would you be offended by that? Especially, no, I would not. So what I hear is really not wrong to send the patient to a higher level of care.
Oh yeah. And I also encourage patients to get second opinions. Like if there's something and you feel that this wasn't right, I'm like, by all means, always always find someone or, you know, get a second opinion. It's never a bad thing.